My name is Dr. Amer. I'm the medical director here at Fairview, and I'm going to be talking today about one of the specific withdrawal syndromes, opiate withdrawal syndromes. Normally I give a lecture at this time and I kind of cover all the withdrawal syndromes, and I focus a lot on alcohol. And we're just going to switch it today for the benefit of a lot of the patients on the third floor who need to know a little bit more about opiate withdrawal and a drug we use for opiate withdrawal called buprenorphine. So I'm going to focus on that in this talk. But for those of you that don't use opiates, that have never withdrawn from opiates, that mostly alcohol is their drug of choice, there's a lot of similarities. You know, you use a drug, you get to use too much of it, you stop using it, you start to have a withdrawal syndrome. A drug is used to get you off of it. There's that early recovery period that is really hard, that you need to work through. So a lot of the similar themes will be coming up in this lecture. So this is a talk about the opiate withdrawal syndrome and how we've changed what we've done to treat it and what we do now. By opiates, another word for that is narcotics, and we mean drugs like heroin being the most common, and then there's all the prescription pain medications that are usually opiates, and that would be morphine, oxycodone, hydrocodone, Dilaudid, codeine, Darvocet, all of those. There's a drug called tramadol, which the generic brand name is Ultram, that also it was marketed as not being an opiate. It's safe, but it goes to the opiate receptors. The drug is just as addicting and the withdrawal is just the same. So first thing I'm going to talk about is what it's like to come off of the opiates, and then I'm going to talk about the treatment, and then I'm going to talk some about buprenorphine, the drug we use to get people off. When people use opiates and stop using it, the withdrawal syndrome begins about 8 to 12 hours after the last use. This is when people, they come in and they've maybe used just before they come in, and then they spend a couple hours in the emergency room, and then they get to the third floor and they start to go through withdrawal. And these are the first things they'll notice. Lacrimation means tearing, watering of the eyes. Rhinorrhea is a running of the nose. They'll start to yawn and they'll start to sweat. If I see somebody at this stage, it's not too bad. They're just starting to feel it. It's more anticipation at this stage than it is real pain or discomfort. If it goes on and it goes into that night, at 12 to 14 hours, they just won't sleep. They'll have a bad night's sleep. They're starting to go into the withdrawal. Now, some people will say, man, it hits them quick, depending upon which opiate they're using. If they're using a real fast-acting one, they can go into withdrawal in 6, 12 hours. But most often, it's not too bad in the first day. At 14 to 24 hours, then they start to go into withdrawal. And these are some of the symptoms. The pupils start to dilate, and that's a variable thing. I've seen people whose pupils just get to be like saucers, and I've seen people in pretty bad withdrawal, and the pupils don't really tell me a lot. When somebody uses a narcotic, if you just use, the pupils get really tiny. Anorexia is a loss of appetite. Goose flesh they will get. They start to get restless. They start to get a little irritable. They start to get a little tremor. You know, they don't get the tremor like the alcoholic. They're not shaking like an alcoholic would, that are just jumping out of their skin, but they do get a little bit of a tremor. They get very irritable. They can't sleep. They lose their appetite. Violent yawning, sneezing. Coryza is like a cold, runny nose and sneezing. Chills, weakness, depression. And then it really starts. Nausea, vomiting, stomach cramps, diarrhea, the pulse goes up, the blood pressure goes up, the sweat goes up. And this is at 48 to 72 hours. At this stage, they're in peak withdrawal, and we usually don't let people with our new drug and with what we do down on the third floor go this long. We don't let them get to 48 or 72 hours. So they don't even get to this stage very much anymore. This is when it's peaked, when they're having to cold turkey it. You know, one of the characteristics of the opiate withdrawal syndrome is they have all these symptoms and they feel like they're going to die. They will just be swearing that their life is just about over, but they're not really in a lot of medical danger. The alcoholic, on the other hand, at 2 or 3 days, the blood pressure goes up, they start to, pulse goes up, they can be in real danger of dying, having seizures, having hallucinations. So the alcohol withdrawal syndrome is actually more dangerous than the narcotic or opiate withdrawal syndrome. But these people, if they were at home and they tried to do this, there's no way they'd go that long. They cannot tolerate this. This is called, the goose flesh goes to what's called plucked turkey skin. They get bone pain. They swear that the drug is coming out of their bones, that it's stored in their bones, is coming, and it's coming out. It's like their bones are opening up. They get muscle pain, and their legs start to kick. They can just sit there and their legs are kicking. If they lie on their bed, the sheets and blankets will be kicked off because they're kicking so much. And I've always found it interesting that that's where the term kicking the habit comes from. It's from the kicking movement that a heroin addict makes when they're in withdrawal. This is the white blood count. That can go up on the lab work. They can get weight loss, dehydration, and I've never really seen cardiovascular collapse with the opiate withdrawal. Then they can go into, before I go on to treatment, they can go into what's called the protracted withdrawal syndrome or the post-acute withdrawal syndrome. And you see that not only for opiates, but with all the chemicals, alcohol, cocaine, benzodiazepines, marijuana. And this is so important to know, particularly for the opiates, because when you come off of this for the first few weeks, for the first few months, even longer sometimes, you're not done with withdrawal. You go into a period of protracted withdrawal. And this is what happens when they come off of the drug that we use, the buprenorphine. They start to feel these symptoms. They will get anxiety, irritability, depression, insomnia. Now, all of these are just due to withdrawal. They're not due to any underlying mental illness. Fatigue, nightmares, headaches, tremor, dizziness, and a lot of gastrointestinal complaints. The characteristics of this protracted abstinence syndrome or this post-acute withdrawal also are there feels like there's a continued need to use the drug that you were addicted to feel normal. And there's continued craving. It eventually goes away, but in early recovery, it's there. There's this underlying feeling that if I could just use the chemical I was addicted to, I'd feel normal. The other interesting thing in this stage is that conditioned stimuli may make people relapse. You could go to a site that you used to buy the drug. An alcoholic can go to a bar. A heroin addict can get a phone call or whatever. And that stimulus then can create tremendous craving. And the other thing it can do sometimes is it can actually create intoxication without using. An alcoholic in early recovery can be around alcohol and feel intoxicated. A heroin addict can put a tourniquet around their arm or put a needle in their arm with no heroin and almost feel it in early recovery. That's just that conditioned stimulus and response. It's pretty interesting. The drugs we use to treat heroin withdrawal or narcotic withdrawal. Methadone we don't use, but I'm going to mention it because it's used other places and it's used around the country, and we used to use it. Methadone, you have to have in order to prescribe it, you have to have a special methadone license, which we don't have. We're not a methadone clinic. Methadone is a narcotic. It's a long-acting narcotic. It's no different than heroin. It's no different than OxyContin, except that it can be given by mouth and it lasts for 24 hours. So it would relieve the withdrawal syndromes, but then you got the problem of what do you do when you're coming off the methadone. There have been different places around the country that have used methadone to detox people off of the narcotics, and they've done it for 3 days, they've done it for 6 days, there's some programs that do it for 21 days, and all of them run into the same problem that when you're done with the methadone, then you go into withdrawal. It doesn't really solve the problem, it just postpones it. How do I get it off of that? Oh, I see. Yeah, there's not much here. The other drug that we used to use is catapress or clonidine. And this is the drug we used when I started here in 1978 up until 2003 when we started to use buprenorphine. Catapress is a blood pressure medicine, and they did studies on it, and they showed that it actually relieved a lot of those withdrawal syndromes. Just going to put this down. Don't worry about the slides. They're not that important anyway. It's better if large doses are used, but the problem with catapress is that it lowers the blood pressure so much that there's a lot of side effects, and you can't give it. If the blood pressure gets below 90, you can't give it. It does relieve the withdrawal syndrome a little bit. We used to be helpful when we could use it on people with high blood pressure. We would stop their high blood pressure medicine and give it. The problem also with catapress is that it had a lot of side effects. It made people have a dry mouth, feel dizzy, just kind of washed out. But it was about the only thing we could use before we had the buprenorphine. The third drug that we used was the benzodiazepines. We've used Ativan, we've used Valium. We still use that occasionally. As you see when I talk about the buprenorphine and you can't use it right away, I'll use some of the Ativan or Valium in the beginning of the withdrawal just to take the edge off. So this helps people be less anxious about their withdrawal. It can help them sleep. It can help them relax. So we do use the benzodiazepines a little bit. Other drugs we use during opiate withdrawal are ibuprofen for pain. We'll use trazodone for sleep. We'll use probanthine for stomach cramps, all to help people get through the initial stage. There are other places, Hazelden, for example, that I still think they use narcotics, other pain pills, to get people off of the narcotics. They would use, one of their big ones was to give people Darvocet. If you were a heroin addict, they'd give you a Darvon and taper down the Darvon, which didn't work very well, and it's actually illegal to do that, but that's what they did. There's something called rapid detox, which you may have read about, or if you watch TV shows, you'll see rapid detox. This is where you give a drug called naltrexone to an opiate addict. What naltrexone does is it takes all the opiates off of the receptors immediately, right away, and puts them into instant withdrawal. So the theory is, let's get all the opiates out of there now, and then let's just give them some catapress and some Valium or something and get the withdrawal over with. Several years ago, I had a woman come to me on December 23rd, and she was an opiate addict. I think it was OxyContin was her drug. And she said, I got to be out of here by tomorrow. I got big kids, I got Christmas Eve coming up. You got to get me out of here tomorrow or I won't stay. So I said, well, there is a method called rapid detox. I've not tried it yet, but if you want to be the first one, we can go ahead. And what we did was we got it all ready. We got catapress, we got Valium, and we gave her a small dosage of naltrexone, and she went into horrible withdrawal. She just got so sick, it was unbelievable. We gave her as much medication we could, and it was faster, but it was just too painful, and so I've not done it for anybody since, except one occasion. There's even something called ultra-rapid detox, not rapid detox, but ultra-rapid detox. This is where you put somebody, you make it so bad and you do it so fast that you actually put them under general anesthesia. And so you give them some naltrexone and you give them some Narcan and you get all the opiates out of their system. And the theory is we can do it so fast that when we wake them up after 3 or 4 hours of general anesthesia, you actually knock them out and breathe for them, that the withdrawal would be done. They've done studies on that now, and what happens is when they wake up from the general anesthesia and they're sent home for the next 5 or 6 days, they have restless sleep, they have diarrhea, they have stomach cramps, they have all the withdrawal syndromes. It just does not work. It just makes it bad initially, but they still have a bad week of withdrawal. They still relapse. It's just, we've had people come here from centers around the country and they're still in withdrawal. So ultra-rapid detox is something to avoid. So the drug that we have now to use for opiate withdrawal and for opiate addiction is buprenorphine. The brand name of buprenorphine is Subutex. There's a form of it called Suboxone, which in the drug, in the pill, they put some naloxone, which is not absorbed, but it prevents people from injecting it, because if they would inject it, they'd go into withdrawal. So the drug is buprenorphine. The brand name is Subutex or Suboxone. And this is, we started using this in April of 2003, so 4 years ago. And we were the first center in Minnesota to actually use it. We did it right down on the 3rd floor. This has been helpful and welcome, and we've been real pleased with it for the following reasons. First of all, the previous detox methods, the catapress, the methadone, patients were uncomfortable and they relapsed quickly. We bring them in, we do the best we can, but they were sick and they'd relapse quickly. Back in the days when we weren't in the 3rd floor, which was locked, we were over in the other center and we were trying to detox people with the old methods, and they would just leave. Sometimes we would use 3 days of methadone, which is all we were allowed to use by law. They'd get their 3 days and they'd leave. We had a lot of people bringing drugs in because they knew they were going to be sick and they'd be using on the unit because it was so uncomfortable. About 80% of patients relapsed. 80%, I would say at least 80%. We would detox them with that method, we'd send them out, and they'd relapse, a high relapse rate. So the only other choice was methadone maintenance. We could take heroin addicts and say, you know, what we have to offer is not going to work. Why don't you go on methadone and just stay on it? And that was, statistically, when they studied it, was the only successful way to treat opiate addiction before. The statistics would show that there was an 80% relapse rate with the other way. They studied methadone maintenance, and it was shown to improve retention at the methadone clinics, to reduce drug screens. But I was always reluctant to recommend methadone for the following reasons. To be on methadone, you have to go to a methadone clinic. You have to stand in line and get your dose every day. And you do that day after day. Eventually, when you've been on it long enough, they'll give you some take-homes. But it's not a good environment at the methadone clinic. There's drug dealing there. There's a lot of bad attitudes there. It's not a good recovery environment. The clinics were reluctant to work with the patients to help them get off the methadone. It was like they treated them kind of like dirt. You take the methadone and you stay on it and come back tomorrow and give us your money. Withdrawal from methadone was horrible. When you had somebody that was on methadone and you wanted to get them off, it was a miserable way to get off. And in fact, a lot of times the only way people got off was to start to use heroin again, and then they could try to take them off of heroin. The thing about methadone is that it goes to the receptors like heroin does, like OxyContin does, and stimulates it fully. It's not like buprenorphine, which I'll get to in a minute. The methadone is what's called a pure agonist. It stimulates the receptors 100%. And one of the best descriptions or comparisons of methadone to buprenorphine, a patient just told me a few weeks ago that had been on methadone for years, and he's been on buprenorphine. And he said to me, you know, Doc, when I take methadone and I get my dose in the morning, I get tired, I kind of nod off, I go home, I relax, but all day long, I want more. I just wish I could have more. Whatever dose I got, I wish I could have had more. And if I know I can't get more, you know, I'm thinking all day long about maybe if I got some Klonopin, maybe if I got some cocaine, maybe if I drink a little bit. There was this sense that I'm just not satisfied. Whereas with the buprenorphine, there's this sense that I take it, I don't feel sick, and I don't really want any more. That relief of the craving, which is really different. Buprenorphine is what we call a pure agonist-antagonist. It is both. It's an unusual drug and a hard drug to imagine, but what it does is that it goes in the body, gets into the brain, goes to the opiate receptors, and it stimulates them and blocks them at the same time. And the best way to conceptualize this, in my mind, is that it stimulates it about 20% and blocks it about 80%. Methadone stimulates at 100%. Heroin stimulates at 100%. This only goes to 20% of a stimulation, only can work 20%. And the rest of the receptors are blocked. So you go up and you can't go any higher. There's this ceiling effect. You keep taking more buprenorphine and you don't get any higher. You're on buprenorphine and you take heroin or OxyContin, you don't get any higher. All the receptors are blocked. And it's that blocking, I think, that's the key. That's the key to take away this desire for more, this hunger for more, this craving for more, which is really, really cool about the drug. There are drugs like naltrexone, which I mentioned before, which go to the receptors, and they're a 100% blocker. They don't stimulate it at all. And I've used that for some people too, and it does take away craving. And in fact, this naltrexone has been used in alcoholics to take away craving, and it works. The problem with the naltrexone is that there's no stimulation so that it doesn't relieve any of the withdrawal. So you can't use naltrexone for getting people off of the drug. You could use it weeks later once the drug is all gone, but you can't use it to get them off. And actually, it doesn't relieve the craving because it doesn't have that 20% stimulation. It doesn't relieve it quite as well as the buprenorphine does. The other characteristic about buprenorphine is that it knocks all the other drugs, all the other opiates, off of the receptors instantly. It just gets them off of there. So we have to make sure that there's not much left in them. That's why we have to wait 24 hours before you give the first dose. If somebody's not truthful with us, they've just used recently, and they take a buprenorphine, the drug that was in them goes off the receptors like that, and that puts them into withdrawal. The buprenorphine only stimulates at 20%, so they actually get worse rather than better. And that's called a precipitated withdrawal. So we have to wait. It's really strong. The other characteristic about buprenorphine is that it really binds to the receptors really strongly. It stays there for 3 days. Some people believe that it stays there permanently and we just turn over our receptors. So it goes to the receptors, it stimulates them, it binds there strongly, and it won't leave for very long. Buprenorphine, if you swallow it, you're not going to get it. It's poorly absorbed in the stomach. It's absorbed only under the tongue. It has a low abuse potential. When I prescribe it and I have people that can take it home and they have a bottle of it, I don't ever see anybody that takes the whole bottle of buprenorphine or that I took 15 today or anything like that, like you do with all the other drugs. There's just no reason to, because you just can't get high on it. It has what's called a ceiling effect. The more you take, it only go so high. The very first patient that we gave it to down on the 3rd floor, we were wondering what it was going to do, and so we were all standing around him, and he put it under his tongue, and we watched him, and he's thinking, I'm thinking it's working, I'm thinking it's working. He said, because he was so used to using heroin, but you just go up a little bit and then you stop. He says, it's the weirdest drug. I just go up and I stop at normal, and I can't go beyond normal, but normal feels pretty good when you've been sick for years and years. It blocks all the other drugs. You know, if you use an opiate, nothing will happen. I've had a couple of heroin addicts that I've had on it that came to me and said that they had to try. They just couldn't believe it, so they did do heroin, and absolutely nothing happened. They completely wasted their money. To get people from heroin or from OxyContin or from whatever they're on onto the buprenorphine, that process is called induction. And we bring people into the 3rd floor to do that. If you give it too early, it doesn't work. If you wait too long, they got too sick. You got to know which opiate they were using. You got to know when that drug is leaving their system. You have to be careful that they didn't have a skin patch of an opiate like Duragesic or a fentanyl patch on, because that's absorbed through the skin for a couple days later. You have to be careful that they weren't skin popping and that they had some heroin that was kind of stuck in their muscle or under their skin or in an abscess if you give it too early. Buprenorphine now is on the streets, and the addicts are trying to use it to detox themselves, but they're not doing a very good job, and they all come in and they say it didn't work or whatever. It is pretty tricky. You got to give the right dose at the right time and go up just right and then go down just right. It's a tricky drug to use, and that's what we bring people into the third floor for. They're usually there for just a couple days. Buprenorphine can be used for two things. You can detox people with it, or you can maintain people with it. Two purposes and two things that I'll go over. Most often we use it for detox. The usual is that somebody will come in, they'll be on the third floor for 2 or 3 days, they'll get started on it, and then they'll go home or upstairs to Lodging Plus or to whatever treatment program they're going to with a taper. They'll taper down over the course. I used to do it for 7 days, then I upped it to 10 days, and now it's about 13 days that we taper people down. That is an important thing. What's it like coming off of the buprenorphine? Some of you are doing that right now, and some of you have done it, and some of you will do it. It is not painless. It's not perfect. It's no perfection. No matter how you come off and how good you feel, there's that early recovery, early withdrawal, protracted withdrawal that I talked about. So there are symptoms, and symptoms are the aches and pains and can't sleep very well. And the thing is that if a person expects it, they're ready for it, they're motivated, they know it's going to happen, it's not going to kill you. It's not that bad. You go through it and you're done and you get over it. If a person expects to feel exactly the same as they did when they first got their highest dose of buprenorphine and not change at all, they're not going to tolerate that. But believe me, this is a much easier way to come off than it is to cold turkey or to use the catapress that we used to use. The main problem then when they get out of treatment is the persistence of the preoccupation and the craving and the wanting the drug, and they're just not feeling well. All of those symptoms in the first few months of recovery. And that's where buprenorphine maintenance comes in. This is legal. Before 4 years ago, this wasn't legal. But Congress passed a law stating that it is legal for doctors to prescribe buprenorphine to addicts. Before that, it was illegal to prescribe any medication like that. There are some qualifications, though. The only drug they're allowed to prescribe is buprenorphine. And the doctor has to get a special license to prescribe it, which requires being an addiction medicine doctor, certified as an addiction doctor, or taking a special course in buprenorphine. And then the doctor is limited in terms of how many people they can prescribe it to at one time. It used to be 30 patients. Now a doctor can apply for more patients, but they put a cap on it, so they just don't want doctors turning into buprenorphine mills. And they're being real careful with this, that it doesn't get out of hand. So the drug must be the buprenorphine, and it has to be that sublingual form. What are the advantages of maintenance? I am a family practice doctor, and I have some people on maintenance in my practice. I've been doing this for 4 years, and it filled up real quick. I thought that what I would do initially is put people on it, and 3 months later, 6 months later, take them off, and I just have this turnover. But actually, it's becoming, as I'm learning about this, it's harder to get people off, and thus it's harder to find room to get new people on. We treat people with this disease of addiction, with opiate addiction, with alcohol addiction, using this drug. We treat it as the disease that it is. This is not a behavior. You are not criminals. We haven't done anything wrong. This is a disease. We have a medication. So we bring people into regular family practice. You come in just like somebody that's getting their cholesterol checked. You sit in a waiting room, you see the doctor, you get your medicine, you take it to a pharmacy, you take it yourself. So it really does treat opiate addiction as a disease, and that I like about it. We see people once a month, and you can talk about how is it going, how is early recovery, are you getting to your meetings? This drug is good because the people can live a normal life. They can do anything. You could fly jets taking this drug. It's not mood altering. It's safe. It can't be injected. And the results are very, very good. I've had people that had addicts that were heroin addicts that had years and years of failure and failure and failure. And like I say, I've been prescribing this for 4 years, and I've had some people now with 4 years of recovery using no opiates for 4 years, and they still come in to see me. And they're doing well. They're sober. It's not 100% perfect. I just had a young guy that he was doing great on it, and he just